It is an honor to be here. And thank you so much for the introduction, Jorge. Salah, you and the Versa team have created such an exciting learning environment, and I am honored to participate, and thank you for the invitation. Today, I'm going to share with you how osseodensification has most significantly impacted my sinus lift procedures. In dealing with an area of reduced bone density and reduced subantral bone volume, there is no overstating the value of primary implant stability or any means to increase it. Now, I was born with an osteotome in my hand, and now I have cut down my use by 80 to 90%. I now have a safer approach to the oblique sinus floor and sinus septum. And what a great aid for the failed or inadequate sinus graft. No doubt, some of my earliest transalveolar techniques are nearing obsolescence, but for me, the lateral window osteotomy is not. I still find it clinically indispensable in a wide, severely atrophic sinus, in patients with pathology, which I must work around, patients with previously failed sinus grafts, and it is the definitive means how you can repair transcrustal perforations. I need direct intraoperative control in these situations, and that is something that a transalveolar approach cannot give me. Now, I've experienced limitations with almost all transalveolar techniques. It's a blinded elevation, and I will assure you that more than half the time you do not detect perforations that you induce. And most often you're going to get a limited degree of elevation safely, 2 to 4 millimeters, maybe 5 millimeters. And you must understand the anatomical constraints, which I will review this morning, of this procedure, its limitations in a wider sinus. And if you look at the systematic reviews, you will see a decreased success rate when you simultaneously place in less than 5 millimeters of subantral bone. Let me share with you my evolution in transalveolar elevation, which is not dissimilar to ZIV's, except I am going to stay in the box, because when I go outside the box like ZIV does, I don't get the same results. I'll begin with the membrane approach osteotomy. We have two goals. The first, maximize primary stability and bone-to-implant contact. The second, access your sinus while maintaining membrane integrity. Now, we know that we have a greater risk for initial implant instability in the posterior maxilla. And if we exceed the micromovement threshold, we will fail. What can we do to maximize primary stability? We all use implants with micro and macro modifications. However, if you paid close attention yesterday to Dr. Coelho's presentation, the idea of osseodensification is so welcome because we're actually improving the patient's bone quality, and maybe in turn, we can reduce the implant surface roughness and reduce the incidence of peri-implant disease. We have traditionally undersized the osteotomy by 5 to 15%. And most of us here are using osseodensification to condense the bone at the apex and periphery. Now, where do we stand with osteotomes? Well, you understand the goal of bone condensation or osteocompression. It's the radial reinforcement or the corticalization of your implant site to improve your primary stability. And yes, if you look at the bone morphometrically, you will see an increase in bone density, but maybe this bone is compromised because of trabecular fracture. And this stands in stark contrast to the process of osseodensification. And if you look at this recent report by our Symposium chairman, Fred Sleet, and Drs. Olin and Prasad, they showed that osseodensification compresses and condenses whole, intact trabeculae versus an osteotome, which fractures bone. The concern? delayed healing response. My summation, there's no advantage of an osteotome technique over conventional drilling, and the benefit does not outweigh the trauma and the risk for vertigo. Let's now access the sinus membrane. I don't care how you get there, you need a working depth, and that working depth will be 1 millimeter shy of your sinus floor. I have found the easiest way to get there is a 2 millimeter twist drill with a stop. Radiographic confirmation is always a good idea. Now you have your working depth. You need to establish your working diameter. And I'll define that working diameter as the diameter at which you access the sinus cavity. If I'm doing a hydrodynamic lift with a piezo surgical tip, it may be 2.8 millimeters. If I'm doing it with an osteotome, it would be at the final diameter of my osteotomy. And if I'm using Arbors, well, it's recommended at 3 millimeters diameter. And once you're at your working width and depth, you're going to access the sinus. And if you're using osteotomes, having this ideal depth and width will minimize the percussive force to infracture the floor, reducing the risk for vertigo. If you are using osteotomes, use them with adjustable stops set at 1 millimeter greater than your subantral bone height. What you would hope to see is a lifting of the cortical floor with the attached membrane, or radiographically, a bowing of the sinus floor. Please, if you are using osteotomes, do not have the patient leaning all the way back with the neck in hyperextension, head up, soft towel, firm pressure on the forehead, reduce your risk for vertigo. Now, from what I understand, many programs in the States are not even teaching osteotome-mediated sinus floor elevation. So let's look at some different approaches. We can use membrane-safe drills or reamers. We can use bone-densifying burrs or piezo surgery. If we first look at a controlled erosion with a drill or reamer, I will intrude these drills in millimeter increments to decorticate and expose my sinus membrane. I especially liked these burrs because they collected a good deal of autogenous bone, and you see how they advance a bone plug in front of the drill to protect the membrane. Alternatively, we can do osseodensification, which we have heard so much about. Bone burnishing, compaction, autografting, running these burrs in reverse, densifying, expanding, and lifting. And the third option, selective tissue ablation using piezo surgery, a safe but painfully slow mechanism. So with access, osteotomy completed, how will you lift? Are you going to use osteotomes, a balloon, hydrants, Arbors, or piezosurgical tips? I'm going to phrase that question a little bit differently. What type of pressure should you use to elevate the membrane with a transalveolar approach? Should it be a point pressure with an osteotome, hydrodynamic pressure a balloon, hydraulic pressure water hydrants, hydrodynamic compression wave with a Arbor, or hydrodynamic pressure with a piezosurgical tip? Let's analyze these. Osteotome-mediated or a bone compaction lift is elevation via a point pressure. But you must understand the limitation of point pressure, especially as the sinus width increases. It is going to take more force to elevate a membrane 4 millimeters in this sinus than in this sinus. More force, greater risk for perforation. In addition, as the sinus width increases, the likelihood that you elevate membrane off of medial and lateral wall decreases. Why is that important? Where does your blood supply to your graft come from? So once your membrane access has been established, you need to verify membrane integrity. Direct inspection, Valsalva, and blunt probing. And you still have no guarantee that your membrane is intact. That is why, for the last 15 years, thanks to Dr. Mazur and Dr. Shkroon, I have used PRF, and it is the first thing that goes in my sinus grafts, lateral or transcrestal, to protect the membrane, possibly seal a small, undetected tear. The TRF is displaced to working depth to protect, lift, and accelerate the healing. And at this point, you must make the decision, do you need to include a graft in your transalveolar lift? So do you need a bone graft with these procedures? Well, let's discuss the rationale first. Simple. Creation and maintenance of more space for bone at the apical port of the implant to aid in support, to give you broader lateral augmentation, to prevent membrane slumping. However, if you thoroughly review the literature, it's really not conclusive on the benefit of this graft at the apical portion of the implant, and I will tell you, it always resorbs to some extent, and it seems to have minimal effect on your success. And not all apical bone grafts you place with the transalveolar lifts provide support. And two-dimensional radiographs can be very deceiving. And transalveolar elevation can be performed without grafting material according to the principles of GBR: membrane elevation, secluded space, stable clot. It works as long as your membrane remains intact. You review comparative studies, systematic reviews, no difference in success whether or not you use graft material. My conclusions relative to the necessity of grafting material in a transalveolar lift: trust me, the choice of your graft material is not nearly as important as membrane integrity. And if you do choose to include a graft material, you will increase your initial lift by 0.5 to 2.4 millimeters, but after 3 years, you may see minimal difference. And the type of graft material or its inclusion won't make much of a difference if your lift is limited to 2 to 4 millimeters. And I do feel that autologous platelet concentrates do add an increased element of safety and healing potential, whether or not you use a particulate. There may be an advantage, yes, in including a particulate graft when you're dealing with a wide sinus, greater than 12 millimeters at your proposed implant apex, or dealing with a more atrophic sinus. You must appreciate the effect of sinus dimensions on bone formation in the sinus. You know, I'm often struck when I lecture at a meeting and I have someone come over to me after the meeting and they say, "Michael, I don't use a lateral window. You know, I can lift 8 to 10 millimeters with a transalveolar approach." And I said, well, that's wonderful, but how much of that bone is now vital? If you have a very wide sinus and you lift 10 millimeters, you may only get 3% vital bone. What does that do to support your implant? Is it solely supported by this cortical bone? So you must appreciate sinus dimension and its influence on your successful grafting. Ideally, I would like to do a staged or simultaneous transalveolar approach and lift membrane equally off of medial and lateral wall. Here, I've done a crestal core elevation procedure. A 5 millimeter diameter core is intruded 3-4 millimeters, and I will graft behind it, much like you would do with a traditional osteotome approach. I get my 10 millimeters of bone, simple implant placement. But you must appreciate how sinus conformation and anatomy affects your procedural success. The wider the sinus gets, it may become more likely you get a very localized elevation of the sinus, dead center. How does a sinus septum affect a transalveolar elevation? I don't know, it varies patient to patient. However, you can see how effective this approach can be in a narrow sinus. A case I did 15 years ago, a core elevation procedure. 15 years later, bone apical, medial, and lateral, because it's a narrow sinus, and I lifted the membrane off of medial and lateral wall. So please, consider your buccal palatal dimension when you select the means, the extent. I might elevate less in a wider sinus than a narrow. The need and the type of graft, I'm definitely going to use a platelet concentrate and try to get autogenous bone in a wider sinus. And I'm going to give a wider sinus a longer healing time. So if you're still using an osteotome-mediated approach, increasing width not only increases your risk for perforation, it also makes it less likely that you're going to have bone on the palatal aspect. You know, owning a CBCT has been a humbling process. I have a chance to look at some of the cases that I did transalveolar lift 20 years ago, and a lot of them don't have bone on the palatal aspect. So let's go back. What type of pressure should you be using for transalveolar lift? I hope that I have clearly shown you the limitations of point pressure. Ideally, we want a smooth, evenly distributed transfer of force for a broad elevation of the membrane. Can a balloon do this? Well, no. It doesn't apply equal pressure to the sinus membrane. And I experienced more perforations with a transalveolar balloon than I did with an osteotome. What about any of these? Can they elevate more safely, more uniformly, and to a greater degree than osteotomes or balloons? First, hydraulic sinus floor elevation. Now, this sounds like it would be the answer because it places equal pressure at all surfaces within the system, eliminating point sources of pressure. There's a problem. The sinus membrane might not be attached equally at all points of attachment, and it may elevate following the path of least resistance. And I've performed hydraulic sinus floor elevation using manually retained or screw-retained water hydrants. And I will tell you, I have not experienced safe, simple, reproducible elevation with these water hydrants. In fact, I'm going to share with you my last attempt at hydraulic lifting using a screw-retained hydrant. I have a 74-year-old female. She's got 2 to 3 millimeters of subantral bone at site 3 and a narrow ridge. I'd performed a controlled erosion with these membrane-safe drills, prepped to 4.1 by 3 millimeters. You see an intact sinus membrane. I insert a screw-retained water hydrant measuring 4.3 millimeters in diameter, and I micrometrically inject 2 cc's of saline. And you know I have absolutely no idea what's happening to the membrane. I can only imagine that this is what is occurring. However, I unscrew my hydrant, and this is what I have. So now, you must make the decision, do you abandon or repair? Well, in order to make that decision, you should have an established transcrestal perforation protocol. And let's make that together. Microlacerations, less than or equal to 2 millimeters, will most likely be clinically inconsequential as long as you have a preoperatively healthy sinus. Let's say that you perforate, you attempt to repair, but the repair is not successful, and you insert an implant 1 to 2, maybe 3 millimeters in the sinus. Please don't be concerned. Most often, your membrane and some bone will grow over the top of the implant. But if that implant's going to go in greater than 3 millimeters into the sinus, you will get a seal of the sinus membrane around the neck of the implant, but the tip of the implant will be exposed in the sinus. It will collect debris and may alter sinus physiology. Should you be placing a particulate after you perf? Well, think about it. You've now lost the ability to generate hydraulic pressure so that you can distend the membrane laterally and apically. You will only now distend it apically. And if you look at a study by Jank, an animal study, 1.2 millimeter perforation, and he then did Bousby or bone-added osteotome procedures, in 85% of the cases, the membrane perforation enlarged. and Garbacia's cadaver study. As the implant reached its final depth, previously induced perfs enlarged as well. Let me ask you, how do you know that the membrane repair that you did is adequate to resist pressure during packing or implant insertion? You don't. And if you look at this study, 2013, they placed 83 implants 1 to 3 millimeters in the cavity through a perforation. 100% success, no sinus complications. Let's now put together our protocol. Here, just for you, I perf at 6 millimeters with a 2 millimeter twist drill. Now, I've perfed at 6 millimeters. I know that after a detected perforation, I will only consider an implant length that is 2 to 3 millimeters greater than my residual subantral bone height, because if it goes in 1 to 3 millimeters, most likely the membrane will grow to cover my implant. If this does not allow for a 4 to 6.5 millimeter diameter implant, at least 8 millimeters in length with an ISQ of greater than or equal to 65, it's a no-go for me. It's not worth it to me. I will delay replacement for 4 to 6 months. I never place a particulate after a transcrustal perf because the vascularity and stability is compromised, in my opinion. I will only place PRF. And here, I follow my guidelines and I place a 5.5 by 9 millimeter implant with a high ISQ reading 2 to 3 millimeters beyond the floor. And it heals at 4 months and it heals at 3 years. Now, I mentioned to you that it is quite often that you will induce a perforation, but you won't be able to detect it. But if you're suspicious of a perforation, all you'll need is this. Confirmation. I was getting too serious. I had to lighten it up. I'm sorry. So let's go back to this. Abandon or repair. Now, remember, I only had 3 millimeters of subantral bone, so that would only allow for me to place a 5 or 6 millimeter long implant. That doesn't fit my guidelines. So either I just place PRF, cover it with the membrane, go back in 4 to 6 months, or I can do a real definitive repair. I don't like to abandon. Lateral window, membrane repair, sinus graft, and those are cortical bone pins I've used to do lateral ridge augmentation. All the graft material is covered with PRF and collagen membranes. Immediate post-op, there's my elevation, my cortical pins, and subsequent implant placement. So I no longer do hydraulic sinus floor elevation, but I thought a better alternative would be hydrodynamic sinus floor elevation, where it's hydraulic pressure subjected to piezoelectric cavitation. So you use a modulated handpiece to create ultrasonic oscillations in this water column. The theory is that this ultrasonic energy induces a cavitational effect, facilitating tissue separation, membrane elevation. So instead of hydraulic pressure, where you have a constant increase in pressure, with hydrodynamic pressure, the water pressure comes in waves and increases in waves, so the membrane stretches and relaxes. First reported in 2007 by Angelo Troedan and his group. I do not have any experience with these tips because they do not fit my piezo surgical units, but Angelo has a lot of publications with great success. I do have a good deal of experience with hydrodynamic piezoelectric internal sinus elevation by D.S. San. And the advantage of these are carbide piezo tips, and they cut faster than diamond tips. I will initially use the 1.6 tip to decorticate the floor. I then will use 2.0 tips to further decorticate, widen my osteotomy. And then there's the working tip, the 2.8 tip, 4 millimeter working end. This is the tip that will elevate the sinus floor. It is inserted 1 to 2 millimeters beyond the sinus floor, held in place for 10 to 20 seconds. Reports, more uniform, more expansive lift versus an osteotome. Just reading it doesn't work for me. It has to work in my hands. And I thought, maybe if this is that effective in lifting, I could use it in some of my elderly medically compromised patients who don't want more invasive lateral windows or lengthy staged procedures. An 88-year-old, anticoags, AFib, medically compromised, 11 millimeter implants with only PRF because he has a history of sinus disease, no particulate. Or this patient, 85-year-old Mr. B, AFib, anticoags. Both the patient and the physician are anxious to avoid very invasive or lengthy treatment. What's the best approach for Mr. B with 3 millimeters of subantral bone? I would ask you, can we expedite his treatment by placing short 6 to 8 millimeter long implants in combination with a transalveolar lift, which would be much less invasive than a lateral window to place 10 to 16 millimeter long implants? You want to be busier in your office? Say yes. Transalveolar lift, hydrodynamic, 8 millimeter long implants, 15 weeks later, and a week later on the other side. Well, if it works in a simultaneous approach, can I use this same approach in patients where a lateral window osteotomy seems too risky to me? And I will encounter the most risky lateral windows at single-tooth sites, where Ziv, actually, is it 1999 Ziv with Michael Peleg? They reported a higher perforation rate in single-tooth sites versus edentulous areas. So here we see a convoluted sinus floor, a vessel and a lateral window, all things that are pushing me away from doing a lateral window. So I use my 1/6 tip, my 2/8 tip. My 2/8 tip is going to elevate the sinus floor. Now, it is really painstaking to graft a sinus through a 2.8 millimeter diameter osteotomy. So I will always widen my osteotomy to 4.1, 4.8. But the first thing that always goes in is PRF. And I graft behind it, cover my osteotomy with a collagen membrane and PRF, immediate post-op X-ray. But look at that, at 4.5 months. I would have been pleased with myself if I got that result and I did a lateral window. And my new rule, bone densification in every stage sinus graft. But now that I'm doing bone densification in every sinus graft, I thought I needed to rethink about what I place in my staged grafts. And I'll touch back on that in a little bit. So I use bone densification, 5x11, final restoration. Now, while these previous cases are impressive, my results, again, are not consistent. I have gotten incomplete lifts, localized vertical lifts. Let me show you an example. A single-tooth site, I've got a thick lateral wall. I've got a depression in my sinus floor. I've got a vessel in my lateral wall. Any way I can avoid a lateral window. Hydrodynamic elevation, 2.8 millimeter diameter osteotomy. I elevate the sinus, widen my osteotomy. There's the lift. So what I have is an incomplete elevation. Can osseodensification provide the additional lift and the palatal bone coverage I need? Because if I do extraction drilling, my implant ends up with no bone on its palatal aspect. Counterclockwise, I insert the implant. I don't insert the implant counterclockwise, but my drills I use counterclockwise. Another case, site numbers 3 and 4, 3 to 4 millimeters of subantral bone. I'm going to do a staged lift. In this case, I use membrane-safe drills to 2.8 by 3 millimeters, and then I infracture with an osteotome with a 4 millimeter stop. No tap, 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 tap. I infracture with an osteotome with a stop. And there's my immediate x-ray after infracture. And now I insert my 2.8 tip, 1 to 2 millimeters beyond the sinus, 20 seconds, widen my osteotomy, graft my osteotomies, cover them with PRF membranes after placing PRF block, progressive addition of my graft material. Graft material appears well contained. Doing it all these years, I still am not sure how much graft material I need to put in. Obviously here, I did not place enough, and you'll see I cover the osteotomy with membranes, PRF and collagen, and look at the localized disappointing elevation I achieve. Yes, more extensive in the narrower portion of the sinus. But I need to place 10 millimeter long implants, but I will require 3 to 4 millimeters of additional lift. My simplest way to get that is with a Densile lift and subsequent placement of my 10 millimeter long implants. This is a fabulous teaching case. 48-year-old, history of perio disease, history of sinus disease. He wants an implant at site number 14. This is how you should evaluate every sinus case. What are your concerns? What is your approach? Okay, remember I said he's got periodontal disease. It's been fairly well controlled, inflammatory process decreased, but he's got vertical defects on these molars. I don't want my implant anywhere near that vertical defect on tooth number 15. There's a sinus septum on the medial wall. If I do a lateral window, how easy is it to elevate a membrane off of that septum? Is that a great risk for perforation? Most importantly, remember I said he had a history of sinus disease. What I have here is a uniform membrane swelling greater than 5 millimeters, ENT clearance to determine osteopatency before I treat. Look at that, depression or convolution in the floor. Doesn't appear to be that easy to elevate a membrane off of that floor. Look at the size of that vessel in the lateral wall. Yeah, maybe I can get around it, but maybe I won't. And if I damage it, it's going to add to the length and stretch of that procedure. So in this case, I opted for a staged transcrustal hydrodynamic procedure. And I do get height, but it's very localized. How do I place an implant at this site? So what I do now in these cases is sinus graft expansion using bone densification. In this way, I can make the most of the patient has. You cannot do subtractive drilling in these patients. 4 months later, high ISQ reading and subsequent restoration. So what I'm basically doing is I'm applying the same principles that we use in ridge expansion and lift to the sinus cavity. But the true test for me, if Arbors were going to replace osteotomes for me, I needed to know that they could handle the work day in, day out in the complicated cases I see most frequently. And those are the oblique sinus floor and areas where I have subantral bone height less than 5 millimeters. Now, certainly at an oblique floor, the lateral window osteotomy can predictably manage it, whether staged or simultaneously. And you know the problem with standard implant drills and osteotomes, they have a high perforation risk, and osteotomes are very traumatic in these sites. Why? Because here you have your working depth. And now, by the time you break through the sinus, you still haven't broken through the top. So the one part of the osteotome is just breaking through the sinus, but the other part is 7 millimeters in the sinus. Perforation every time. So we needed an alternative means to lift safely at an oblique site. Osseodensification has provided this for me in all these cases. very severely oblique sinus floor. Look at the apical and lateral distal displacement I get with the sinus floor and bone densification. I could not have done that with an osteotome. And this is how the nature of periodontal practice has changed in Manhattan. Many of my general dentists that refer me patients, they place implants. That's their prerogative. My job is to teach them and explain to them those cases that they might not want to place implants. If I've done that, then I've done my job, and they'll still send me patients. And this is a good example. Referring dentist extracted the tooth, but he's concerned about the bone quality and the slope of the sinus floor. Osseodensification will lift the oblique floor and give me enough stability that I can utilize a single-stage approach. High ISQ readings and restoration. The next challenge was, can osseodensification outperform an osteotome at sites where I have less than 5 millimeters of subantral bone? Here I do progressive widening of my osteotomy, and there you could see when I'm at 4 by 4, you see the membrane? Doesn't worry me, because I know as I progressively widen this and I displace my bone apically, I'm not going to see that membrane. So I elevate at the 5 millimeter diameter phase, radiograph to show how I have decorticated the floor, graft PRF, my PRF block in counterclockwise rotation, and a subsequent lift of 2 to 7 millimeters with an incredibly high ISQ reading on a 6 millimeter diameter implant. Another case, a little wider, flatter sinus floor, 4 millimeters of bone. Here I follow the recommended guidelines, 3 by 4 millimeters. I will then elevate at the 3 millimeter diameter, elevating the sinus 2 to 3 millimeters with my densile burrs, progressively widen at my new working depth, graft my material, first PRF in a counterclockwise rotation. Day 0, 78, 3 months, 84. But what I will tell you, if you follow these cases where you've grafted bone and you have a wide sinus, you're going to see a greater degree of graft shrinkage. It will not affect your success, though. But the clincher for me was this case. It had so many things going against it for an osteotome-mediated elevation. An oblique floor at number 4, only 3 to 4 millimeters of subantral bone, and a septum at site number 3. And with osseodensification, I was able to achieve this with subsequent restoration and 3-year load. But I still have not found the means using a transalveolar approach to manage severely atrophic sinuses. I still need to lean on a lateral window osteotomy. So I thought maybe if there's not one single transalveolar approach that can manage it, maybe if I combine transalveolar approaches, I can handle the more atrophic sinus. Extraction of number 14 leaves 2 to 3 millimeters of bone in a very wide sinus. Now, yes, day in, day out, I could do a lateral window osteotomy on this case, but that's not the test. I'm going to first create a crestal core that's 6 millimeters in diameter, 2 millimeters in depth. And in the center of this core, I'm making another osteotomy, initially 2 millimeters, but it will be wide enough to insert a hydrodynamic tip and elevate the sinus before I intrude the core. Now, why am I doing this? Because I know in a wide sinus, if I simply elevate the core, I may get this result. And then I have a difficult implant placement. But if I elevate first hydrodynamically, maybe I will get better membrane elevation off medial and lateral wall. So there's my 2.8 millimeter central osteotomy. I insert my piezo tip, elevate the sinus, and place PRF in the small osteotomy. Now, I use an instrument I designed, a core osteotome. It rotates around the core, and it infractures the floor of the sinus so that I can intrude the core 3-4 millimeters, graft PRF block into the core osteotomy, apically displace it 2 or 3 times, cover it with a collagen and PRF membrane, and here is my immediate post-op x-ray. But what's more impressive is my 5-month CBCT. So the principle worked. And always, osseodensification in my staged sinus grafts. Improve what I have. Make the most of what the patient has. 4.8 by 10 and restoration. And a similar case, you could see the challenge of doing a lateral window osteotomy in this case with the convoluted floor, vessel, and whatever that is on the buccal aspect, because it's certainly not bone. So I create a core, a central osteotomy, elevate the sinus, intrude the core, immediate post-op x-ray, and I've got my 10 millimeters of bone and a better ridge. But here's where the learning starts. I use a Densar burr to prep my osteotomy. And I place my 4.8 by 10 millimeter implant. But I'm trying to densify a xenograft. Does xenograft behave biologically like trabecular bone? We're going to answer that shortly. Here's another case, 3 millimeters of subantral bone. I'm going to elevate a core dead center of this ridge. There you see the core osteotomy. I use my core osteotome to directly infracture the floor around the core. I intrude the core, graft behind the core, cover it with a membrane. Now remember, here, I have only used xenograft. Xenograft, that is it. I cover it with a membrane, and here at 4.5 months, I have almost 10 millimeters of bone. And I'm going to use my bone densification because that's what I used in my staged sinus grafts. I'm densifying entirely xenograft. And when I withdraw, what do I see? My first Densar perf. Xenograft does not respond like hydrated trabecular bone. Freshly hydrated trabecular bone is a ductile material with a good capacity for plastic deformation. You must understand that bovine bone mineral has only inorganic content, just provides bulk without viscoelasticity. It doesn't move well. It doesn't move like trabecular bone. Hence, the perforation. So let's go back to my protocol. Remember what I said, I perf. No particulate, only PRF. And here you see I've perfed at 8 millimeters. That means I can put a 10 or 11 millimeter implant. High ISQ, 4.8 by 10. For stage placement, both lateral and transalveolar, I use PRF, autogenous bone, cortical cancellous mineralized freeze-dried bone, no bovine bone mineral, as osseodensification is always used to prepare my osteotomy. I'll finish with this case. I'm going to do bilateral sinus grafts on this patient at site numbers 3 and 14. Let's decide on my approach. Beginning with site number 3, I've got 3 millimeters of subantral bone. For me, that's usually a staged sinus graft. I've got a thick lateral wall. That's going to make a lateral window osteotomy a little challenging. I have a narrow sinus, which means I can probably elevate both medial and lateral membrane off of the walls if I use a crestal approach. And if I use a lateral approach, it's going to be a little hard to dissect that membrane off of the medial wall with the sinus septum. So here, I'm going to use solely bone densification and do a staged approach using a Densar lift. I widen my osteotomy, intrude my Densar drills 2, 3, 4 millimeters, graft behind it by rotating my burr in reverse. I cover the ridge with a membrane. There's the immediate post-op x-ray, and I wasn't that impressed with it. I said, I'm going to have to get more when I go back in. Let's go to the other side. Here we have 2 millimeters of subantral bone, a thinner lateral wall, a wider sinus, and an internal anatomy that I could elevate nicely with a lateral window. My lateral window, my sinus graft, and 5 months later, using 2 different approaches, I've got my 10 millimeters of bone. And this is how I practice day in, day out with my sinus procedures. What I am doing is I am performing, well, here's my Densile lift. I'll show you that. There's the bone densification at both sites and subsequent placement of 4.8 by 10s. And I feel comfortable enough having a tooth or an implant in a graft as my terminal abutment if I have ISQ readings of 80 and 84. And as I said, this is how I practice in my sinus procedures. Customized sinus lifts. I apply the least invasive, yet predictable approach based on the patient's sinus anatomy and sinus compliance. The sinus compliance is the sinus's ability to return to its homeostatic status after you invade it. In conclusion, what has osseodensification done for me lately? It's become an invaluable asset in the management of failed or inadequate sinus grafts. Here is a patient who was referred by another surgeon after she developed an infection after a sinus graft. And he said, Michael, I know we're not going to go back in and do a lateral window. Is there anything you can do from a crestal approach? And I used bone densification to place 8 millimeter implants and make the most of what the patient had. It has significantly enhanced my transalveolar approach to the more atrophic sinus, where I do not want to perform lateral window osteotomies because I believe they are high risk for complications. It has improved, but not replaced, my lateral approach, as osseodensification is always used to place the implant, either in a simultaneous or staged approach. But it has eliminated bovine bone mineral from my staged sinus grafts. And it simplified the simultaneous treatment of a narrow ridge and a low sinus, improved my safety profile at the oblique sinus floor and sinus septum, minimized trauma, and simplified the lift in transalveolar elevation, and reduced my detectable membrane perforation rate in transalveolar elevation. And it has improved my success at sites with less than 5 millimeters of subantral bone. To the point where all the sites that I previously used osteotome-mediated sinus floor elevation and simultaneous placement are now treated with a bone densification lift procedure. Thank you.